Hello everyone, welcome to the class of dysphagia. Here we are going to introduce the term dysphagia, the swallowing difficulty. So we all have a normal pattern of swallowing. So we need to understand the adult anatomy, physiology, swallowing issues, assessment and the treatments. So in the anatomy, we have to deal in detail about the structures that includes in the OPME examination as the lips, tongue, palate, uvula, teeth, jaw, buccal mucosa, floor of the mouth, salivary glands. Palate includes soft palate as well as hard palate. And the cranial nerves, which are important for swallowing, that is the fifth cranial nerve, seventh, 9, 10, 12. And all the cranial nerve examination should be studied by undergraduate students. And we have to discuss about the laryngeal crepitus, reflexes included in swallowing, like gag reflex, swallow reflex, and laryngeal adductor spasm or laryngeal adductor reflex, and the reflux, which is actually a pharyngeal or gastric backflow of the content. So before we go on to the anatomy, I have to still tell you that this is a very brief introduction to dysphagia. So we'll be going a little bit fast. So the structures which are involved in the mechanism of swallowing will be discussed, especially the central pattern generator, that is the central nervous system control of the swallowing mechanism, and all the structures, as I said, the uh, are all the structures which are important for our speech as well as our swallowing function. That includes all our passive and active articulators. And the oral cavity contains structures which help us to contain the bolus inside the oral cavity. Whatever we swallow, that could be a liquid or a solid food, which is called as a bolus. So the containment of this bolus inside our oral cavity and then passing it into a appropriate texture to the throat with the help of the salivary glands, which secretes saliva, which is helpful in breaking down the substances and also for absorption. And all the articulators, especially at the level of the oropharynx, that is in the level of the posterior pharyngeal wall and the anterior facial pillars, as you see in the picture. Here exactly starts the swallow as a reflex. So the control of the bolus is taken by the central nervous system directly. Thereafter, you don't have to worry about what you're swallowing. So that exactly is the point where the swallow becomes a very crucial act of our physiology, because after the point of this oropharynx, just after your soft palate, when it reached at the level of the oropharynx, the food has to decide whether it should enter to the hypopharynx or to the airway. Normally, it should be going to the hypopharynx to the esophagus. But in some pathological conditions, there is chances where it can interfere into airway mechanism because of an abnormal coordination. So that is also to be monitored. And swallowing is a very complicated act, and the disorders of swallowing, uh, most complicated section is in the pharyngeal stage. But there are disorders which includes in the oral stage as well as the uh, esophageal stage also. But we frequently deal with the pharyngeal swallow issues. In the oropharynx, the action of food, that is the pumping propulsion mechanism of the back of the tongue, takes place, and same way the pressure from the upward from the palate region, from the lateral sides of the pharynx, and this pressure creates a negative. This pressure helps the lower part of the pharynx, that is the upper esophageal sphincter, to release and relax, so that the food pass through the sphincter and gets into the esophagus. So there are some constrictor muscles as well as squeezing muscles are there, which act as a pathway to the food to go into the esophagus. So this is the view of your larynx. You can identify your cartilages, epiglottis, and vocal fold also you can visualize in this picture. So this is how when you see, this is the way you see a larynx. This is in the anterior part you have the epiglottis, and the posterior part you have the esophageal inlet. This is exactly the area where the upper esophageal sphincter is there, and it gets opened up once you swallow. So the epiglottis will go and cover the airway and helps the bolus to pass through it and it into the esophageal inlet. So without the structures, if you see the larynx in a row, this will be the cartilages and hyoid bone is also seen in this picture. So the anatomy and development and physiology together is required for understanding the fact of swallowing. So when you keep the bolus in your oral cavity, it has to be masticated properly. If it is a solid food or if it is a liquid, back of the tongue has to elevate and control the flow of the liquid and gradually propel it into the throat. And from throat, it should coordinate the pathway of breathing and it should be transported directly into the pharynx. So the primary function of our larynx is airway protection, and the three stages of swallowing has two phases also, that is on the oral stage. In adult swallowing, oral preparatory phase and oral transport phases are there. So this is given by American Speech and Hearing Association, and this description fits onto the adult physiology. So oral preparatory stage is a stage in which the food is prepared for swallow, and oral stage is the bolus is transmitted into the pharynx in the stage. In pharyngeal stage, bolus is transmitted to the esophagus, and numerous physiological responses will also take place during this time. Esophageal stage is the time where the food is transported from the upper esophageal region to the gastric cavity or the stomach. So it's all a part of digestive mechanism. The swallowing apparatus is actually included in the digestive tract. There are few terms which may be new to you guys. So that is dysphagia or disorder of swallowing. That is swallowing disorder. Simply people say swallowing disorders, but the technical term will be dysphagia. And a speech language pathologist dedicated to treat dysphagia will be deglotologist. And bolus will be the ball of food or liquid that has to be swallowed. Mastication is a process of preparing food for the swallowing. So it's like chewing. Moving food from grinding surface of the teeth, mixing it with saliva, then propelling it with the tongue on the lateral sides. So deglutition is a process of swallowing. Both above concepts are quite integral of the lingual velar, that is soft palate, pharyngeal facial movement, and laryngeal adjustments and the respiratory control. The perioral region is the region around the mouth. So when you want to stroke this perioral region of the child who is less than 6 months old, you will elicit a sucking reflex. So rooting reflex is a reflexive response of infant to tactile stimulation, the touch stimulation of the cheek or lip. Infant turn towards the stimulus and opens the mouth. So sucking reflex, tongue protrusion and retraction in preparation for reception of the liquid stimulated by the contact of the upper lip or the perioral region. Esophageal reflux is an abnormal condition. It's a regurgitation of the food into the hypopharynx. Nasal regurgitation, otherwise called nasal backflow, is a loss of food or liquid through the nose, which is mostly due to the soft palate deficits or can be a structural or a functional incompetency. Peristaltic is the wave-like motion by which the food is passed from pharynx to esophagus and also esophagus to stomach. So there is pharyngeal peristalsis as well as esophageal peristalsis. And oral transit time is a time required to move the bolus from the point of initiation of the pharyngeal stage of swallowing. And pharyngeal transit time is the time required to move the bolus from the beginning of pharyngeal swallow to the entry of the esophagus. How will you do a swallowing evaluation in adult? So the evaluation of any swallowing case requires a proper detailed case history. Sometimes the patient may be reporting all the issues that the patient is facing. Sometimes we have to rely on the primary person who is there with the patient. Could be a parent of the child or could be a family or a bystander of the concerned patient. So it's always better to elicit the information from the most reliable source. And then you have to proceed to clinical bedside evaluation if the patient is giving you the consent, as well as the patient's ability should be also checked before you enter into the clinical bedside evaluation. So after this bedside evaluation and your screening procedures, you will decide whether you should go to the instrument evaluation. It's not necessary that you have to always employ a instrument evaluation to decide and diagnose the treatment plan. So first in the history, case history section, we have the demographic data of the patient, basically the name, the gender of the patient, age of the patient, occupation, and their locality, and anything to be documented specifically about their diet or something, we can add it in the case history section. And you have to observe their feeding. Mealtime behavior observation is the most crucial key that is giving you an idea of whether it is a feeding disorder, swallowing disorder, and how you should tackle the problem. So see how the patient is getting fed and who, why, where, and with what utensil you're going to feed the patient. It's very important. So where lies the problem? In some cases, like a non-case of a cancer or of the oral cavity or the throat or wherever in the body, due to any particular surgery related to your larynx or your thyroid, any palsy like facial palsy or vocal cord mobility diseases, or due to fistula in any of the digestive tract, paresis or paralysis of a structure, secondary neurological disorders like cerebral palsy or any Parkinsonism or stroke, pediatric or geriatric diseases. These conditions quite predictable where lies the swallowing problem, isn't it? So we know exactly because of the surgery this might have happened, or the particular structure which is involved in the syndrome or disease is also revealed to us. But what happens when it is an indirect issue? The patient will just come to you and report that they're having a difficulty in swallowing. Could be a pain while they are trying to swallow their saliva. Could be a difference in the mechanism that they are perceiving while swallowing. Odynophagia is pain while swallowing, and those patients who always have a bolus sensation in their throat could be because of a GERD or can be because of a foreign body ingestion. A 2-day old bone swallow, like a bone stuck in the pharynx due to a accidental swallow, can also cause a bolus sensation sometimes. And when it becomes infectious, you will have odynophagia and severe odynophagia due to the as the infections increases. And sometimes the patients will always may report like a altered sense of taste, and a lot of secretion is coming out of the oral cavity, and the change in voice is also a indirect sign that you're having a swallowing disease. So how to go with the evaluation? As we said, once we complete the case history, we have to make sure that we are going for the clinical bedside evaluation. So there are only two goals for swallowing therapy. One is the safety of the patient. How safely can you administer the swallowing mechanism for the patient, and how effectively. So you should be knowing that after a proper feeding, the patient should be feeling safe for feeding. There should not be any breathing deficit or anything that is going to hamper their normal lifestyle. And you should make sure that the patient is getting adequate nutrition support, and it should be quality food and quality feeds. It is not about the quantity that they eat, that should be properly absorbable and adequate for their daily living activities. And the other goals will be continuation or possible modification diet. In case if you feel like the patient will be surviving better with a modified diet for a temporary period, you are allowed to provide such advices to the patient. And in case if the patient's problem is not managed by a single person alone, we can always opt for the, and we should always opt for the multi-dimensional treatment or our multi-speciality treatment. So all the specialists that has to work in a swallowing disorders. So we say multi-disciplinary treatment can be introduced into the practice. And if you think the patient requires a specialist to be referred, and you cannot manage the patient, or you need a second opinion, or the patient prefers to conduct a detailed examination, then you can refer the patient to the nearby or your expert for an expert opinion. You can conduct telemedicine rehabilitation services, like forming a group of specialists together, and you can discuss that in group. It can be done in the inside your place, inside your locality, or in international level also. Then arriving at a medical diagnosis, sometimes the swallowing deficits will be the initial points which trigger to know that the patient is having an underlying serious condition. And if there is a need of further assessment, you should go for it. Just don't stop with your screening procedures. Always you should go forward. And what are the critical components? While you assess a patient, the critical components that you have to keep inside is that the chief components and the current status of the patient related to dysphagia. And all those things that the patient report you may not be related to the condition that they are experiencing, but just listen to them and screen out which all things can be correlated to the clinical symptoms that they are presenting now. How did it started, and is it common for liquids, food, and pills and all the taste conditions? And was there any recent pneumonia reported by the patient? It cannot be a pneumonia always, but it can be cold or fever chills. And any recent hospitalizations or need of medications. associated voice changes, present and past illness, any continuous medication, including allergy medicines, any previous or recent trauma, including psychological, social history and habit of feeding, family history, review from other specialties. Usually, they might have gone to a physician before they reach you. Signs and symptoms of dysphagia. As you all know, there could be prolonged feeding or fatigue. While eating, the patient is getting tired, or he or she requires a longer time than the usual companions in their table, and drooling while trying to eat something, or because of this increased secretion, they are not able to enjoy their food. Choking or coughing or throat clearing. So, choking is different experience other than coughing. I've heard people using these two terms intermittently and synonymously, but actually, choking is when you have a breathing deficit along with your uh, difficulty in maintaining a proper airway, and coughing is just clearance of your throat is, you all know it's a bad habit for voice, but people do it to experience a little better. And weight loss or change in the diet recently, dehydration, temperature spike, pneumonia, pocketing of the food or mouth odor. Sometimes children used to keep their food inside their oral cavity because they are not concentrating much on their chewing. And for geriatric people also, because of the absence of the teeth and absence of their tongue mobility, sometimes pocketing of food happens in between the gingival buccal sulcus, and there can be a gurgly or wet voice when there is a pharyngeal dysphagia. A lot of the secretions present, then definitely you will have this. Some patients will have some kind of stridor also. And rejection of the food selectivity, gagging. These are the signs of eating disorders also. Sorry, feeding disorders. So don't confuse feeding, eating, and swallowing disorders. They are not similar things. They have little bit difference among themselves. We'll discuss it in the future chapters. So, what could be the clinical findings that we are getting here? Coughing or choking, frequent throat clearing, multiple swallow pattern. So, for a single spoon of water, how many times should we swallow? If it is a teaspoon or tablespoon, also, an adult needs only one swallow to completely clear that one teaspoon or tablespoon of water. But if somebody is taking 2, 3 gulps to clear that one single spoon of water, that shows there is something abnormal with them. And wet voice quality. When you're speaking, your voice is not clear. It is having some kind of secretions along with that. And being edentulous is like absence of a teeth, absence of a proper dentition will lead to a lot of infections. And drooling. When you're having an anterior spillage or your saliva is just pouring badly outside, it can also go inside also and cause a silent aspiration. So aspiration is anything other than air getting into your airway and uh, causing trouble to your swallowing. This causes definitely some airway disorders also, like infections will develop into pneumonia. So increased oral or pharyngeal secretions and cyanosis, the absence of air which causes the bluish coloration in the body, and shortness of breath, weight loss, bronchoria, increased mealtime spiking, pulmonary infiltrations, resistance to take orally, food pocketing and sticking already discussed, and changes in the mouth and the taste, difficulty in managing foods or specific texture or sensation. Sometimes when they feel difficulty in one particular texture of the food, they might switch on to the other one. It's like when you see the adult, old age people, they don't like taking hard solids. They prefer to take soft solids or liquids or blend. And the aberrant behavior pattern when the food is presented, they show some kind of phobia towards the food and aversion also sometimes. So what could be the pre-feeding assessment? So the screening is mandatory for any diseases. And a screening should be quick in non-invasive and low-risk procedure. You are not going to insert anything into the body and do a screening. Based on the chart reviews, the chart of their temperature, their feeding, their output, medicine chart, and everything you have to study if it is possible and it is given to you. There should be a brief patient observation of their behavior, their communication, and how they approach the food, and determine the presence of dysphagia based on the overt symptoms that they're showing. And whenever you're doing a screening, whether it is for hearing, speech, or swallowing, or whatever, it is not a final answer to the patient. So do not disclose or give a diagnosis after the screening. Do a proper screening and have a proper diagnosis with you. Then only you can disclose that with your patient. So you have to clearly ask questions and also get the report of these few things about their swallowing. How did it started? How long it has been like that? And how frequently they experience it and which are consistency of food? And how is it, whether it is progressing or getting better or having a status of static status, and how is it presented when it comes, how do you feel about it, and what are the sensations like pain or discomfort, how do you experience it properly. You have to ask the patient, and then you have to do the oral motor examination very detailedly with the structural and physiological as well as the sensory reflex testing should be done for them. Then you observe how they are eating, their reaction, the alertness to the people in the room, and how they are enjoying the food and how their interaction, their social eating habits. And then we have to discuss about few things like if you are not working in a hospital, then you should be familiar to identify some terminologies that will be reported in the medical file. So that is Glasgow Coma Scale. Like when you're going to assess a neuro patient, how much the patient is alert, oriented, and able to speak out, that is given by the score from the Glasgow Coma Scale. And read the history relevant for your service from the medical charts, investigations ordered by the physicians, the primary issues faced by the patient, what all procedures are already done to the patient, is there any special breathing tube or tracheostomy for them, are they on BiPAP or CPAP or any other kind of pulmonological devices, and see their blood cultures and the reports. And if it is possible, try to inquire all the details from the nurse also. They might help you to understand these medical terminologies. Then you go for your area assessment, the laryngeal functional assessment. You can take a simple MBT of the patient and identify if they are having a good laryngeal status, talk to them, record their voice, assess their voice perceptually. Not necessarily always you have to employ instrument evaluation for assessing their voice alone. But if you think there is something suspicious, don't mind go for a laryngoscopy. And if it is required, go for the specialized laryngoscopy test like FEAST or any other test that you prefer to do in the patient. And give an auscultation to the chest area, find out the respiratory status of the patient, check for their breathing pattern also. And during the initial swallow assessment, you have to see whether your patient is able to identify your instructions properly, able to follow the steps that you're doing, demonstrating all the mechanisms of breathing and postures that you are advocating on them. And then only you consider giving them a food and going to do for the testing. And when you're going to do a screening or an evaluation with the kind of food that you're presenting, you should be confirming that with the patient status also, like how you're going to make the patient sit, how you're going to protect them if something goes wrong, and what kind of food you are going to introduce, in what quantity and texture, and who is going to place it in the mouth, and how you are going to place the, and if the patient is having any difficulty, how will you retry the patient. So make sure that if the patient is normal or abnormal, have a small crash cart near you, have people around you to help you to do suction or help the patient come out of the difficulty when they are experiencing a choking episode. And observations during the trial. When you are giving the food trial, make sure that you can manage the patient with a lot of manuals that is possibly done at the bedside. Whatever care you see, take and whatever you observe outside, if everything seems normal, still 50 to 60 percentage of silent aspirators are there. Like when we give a small amount of food, if the patient is coughing, that's a sign that the patient is not fit for swallowing. But there are patients who don't show any overt signs but can be under the criteria of the silent aspirators. So the observation of the mealtime behavior give a lot of clue about how the swallowing can be proceeded. And based on that, is it enough for us to stop the assessment and go for the instrument evaluation? How will we decide what to do the next things? So you need a little bit of understanding about the problems again. So the effect of dysphagia in your normal life, you will not be aware of the social effect of dysphagia, because we all feel like it's because of a main disorder we are having dysphagia. But what if the main disorder is resolved and still the patient is having a bad quality of life and they're compromising their social life because of a difficulty in feeding? They cannot enjoy a common meal with their friends and family. They cannot be participating in a common function, and their family has to always carry their food because they may be eating a special kind of food. So this affects their physical, mental, and overall financial, social status also. So dysphagia is a hidden handicap. It has got a lot of aspects in our daily life. I just wanted to cover this brief introduction to dysphagia today. Thank you. We need to know that always early intervention lead to a better prognosis. But when we have a dysphagia, it is going to be fatal to our life. Like it can be a cause of our death also, unlike a communication handicap. So we should identify it at the earliest and give the treatment also at the earliest. Thank you.